Next bill is going to be House File 970. The chair moves that House File 970 be recommended for referral to the Human Services Finance and Policy Committee. We do have an author's amendment, and this is the bill's first hearing, so the chair will move the A1 author's amendment to put the bill in the shape the author would like for consideration by the committee. Representative Bang, welcome to the committee. Is there anything you would like us to know about the amendment before we adopt it?
Thank you, Mr. Chair. This amendment, while making this bill, we forgot to add the Board of Psychology, so this amendment just adds that to the bill.
Okay, thank you, Representative Bang. This being an amendment, author's amendment, this will be a voice vote. If you could unmute yourselves, would all in favor of the amendment signify by saying aye?
Aye.
Aye. Those opposed? The amendment is adopted. The A1 amendment is adopted. Representative Bang, please present your bill as amended.
Thank you. Mr. Chair, I believe we also have another amendment too. Should we do that one first before I proceed with the bill?
Why don't you go ahead and present your bill, and then we can go to the A2 amendment that is proposed out there.
Sounds good. So thank you, Mr. Chair and members of the committee. I'm happy to present House File 970. This bill addresses a long-running problem, a shortage of mental health providers. For a long time, poor access to mental health care included rural communities where individuals are less likely to have a mental health treatment facility than metro counties. Communities of color are less likely to get treatment, the treatment they need, and low-income communities are less likely to have mental health treatment resources than high-income communities. So this bill brings comprehensive support and addresses a number of things in which my testifier will go through the bill to elaborate on each section. I think what's important to highlight is the amount of work that has been put into this bill to address this workforce shortage. This has been a result of coalitions and advocates working across the state to create these recommendations that now shape this bill. In 2013, the legislature passed a bill requiring the Minnesota state colleges and universities, MNSCU, to convene a task force to develop a comprehensive plan to increase the number of qualified people working at all levels of our mental health system, ensure appropriate coursework and training, and to create a more culturally diverse mental health workforce. Meetings were held across the state, surveys were conducted, and a large summit was held. The report is entitled Gearing Up for Action, was submitted to the legislature in January 2015. Some, but not all of the recommendations have been implemented, and several key issues remain. These include: 1, ensuring access to and affordability of supervisory hours; 2, requiring all third-party payers, commercial insurers to reimburse in the same way that medical assistance does for supervision internships, so that services provided by mental health trainees under the supervision of a mental health professional are reimbursable by third-party payers, commercial insurance plans. 3, create training programs and stipend scholarships and pathways to licensure targeted at students from diverse communities. And 4, improve and expand cultural competency awareness training. The Wilder Foundation, the Mental Health Improvement Work Group, co-led by NAMI Minnesota and the Department of Human Services, also played a role in helping shape this bill. And with that, Mr. Chair, I'm happy to have my testifiers proceed on the importance of this bill.
Okay, and I also know that we referred to the A2 amendment. What I'm looking at here is we did say that we take up the A2 as soon as you're done with your explanation there. So the A2 amendment is presented by Representative Frankie. Representative Frankie, do you wish to move that amendment and give us a brief explanation?
Yes, Mr. Chair, thank you. I'd like to move the A2 amendment.
Okay, Representative Frankie moves the A2 amendment. Representative Frankie, if you'd like to give a quick explanation.
Thank you, Mr. Chair. Thank you, Representative Fang, and thank you for the discussion yesterday about this. The A2, just page 13, line 12, after the comma insert, as defined in section 148E.010, subdivision 20. In all of these other boards and task force, we do have the new language being added with the definition underrepresented community as defined in section 148E.010 subdivision 20. Let's just say, for instance, on line 7.2, it is there. But when we got down to the other task force, that language was not defined in underrepresented communities. So I just wanted to make sure once again that we're covering everybody, all the groups that are mentioned, and keeping the bill consistent moving forward. And that's my amendment, Mr. Chair.
Okay, thank you, Representative Frankie. Representative Bang, your comments on the amendment.
Thank you, Mr. Chair, and I would like to thank Representative Frankie for your eagle eyes and making sure that we remain consistent throughout the bills. This is a friendly amendment. I support it.
All right, thank you, Representative Bang. This will be a voice vote if everybody could unmute themselves. This is the motion to approve the A2 amendment as presented by Representative Frankie. All in favor signify by saying aye.
Aye.
Opposed? Motion carries. The A2 amendment is adopted. Thank you for that. And we'd like to go then to the testifiers for the underlying bill. And the first person we have is Ms. Sue Abderholden. If you'd like to introduce yourself and who you're with and start your testimony, please.
Thank you, Mr. Chairman. Sue Abderholden, Executive Director of NAMI, Minnesota. I have 4 short slides. If Mr. McCall could put them up just to provide some data for folks. On the first slide, and you can see these are from the Minnesota Department of Health, Office of Rural Health and Primary Care. So you can see the blue is the supply that we currently have versus the green bar, which is the demand. And so you can see that our supply is not close to meeting the demand for mental health professionals in Minnesota. Next slide. This slide shows that we have people who graduate with degrees, but then they don't become licensed. And so that is very concerning. And we know part of it is due to difficulty getting supervision and some of the licensing tests as well. And so just wanted to show people, excuse me, that gap. Next slide. And then this shows the loan forgiveness program, which really has helped increase and keep our mental health professionals in Minnesota. You can see in terms of psychologists, clinical social workers, marriage and family therapists, licensed professional clinical counselors, and the psychiatric nurse specialists. So we have been able to serve 133 people, 92 in greater Minnesota, 41 in the urban underserved areas. Next slide, or maybe. And then this just shows you the median wages. So we know kind of big term, we need to really think about some of the rates that we provide our mental health providers. But you can see in comparison to, dental hygienists or respiratory therapists versus, our clinical social workers. And I think that's the last slide. Thank you. So as Representative Bang said, we have actually had a workforce shortage forever. We've never had enough mental health professionals in the field. And we are particularly seeing a shortage of BIPOC mental health professionals right now. And so in order to really meet the needs, especially in light of the pandemic, we need to start doing something. And again, we've had that report since 2015, many good things in the report, and we need to finish. But I want to say that this bill is really based on the feedback of people with mental illnesses and their families, our community mental health agencies, our mental health professionals, and students as well, and including professionals from the BIPOC community. You're going to hear from professionals, but I just want to point out that the lack of a robust, culturally diverse and informed workforce leads to poor outcomes. Studies show that people from BIPOC and LGBTQ communities are less likely to access quality care, are more likely to use the emergency room, and are more likely to end up in the juvenile or criminal justice systems where they access care for the first time. Lack of a culturally informed workforce also means, for example, that Black men are 4 times more likely to be diagnosed with schizophrenia than PTSD in comparison with white men with the same symptoms. People from BIPOC communities are less likely to be offered therapy. People who are Black are more likely to receive care in an inpatient setting. Asian adults have the lowest percentage in outpatient service use, and the suicide rates, particularly in the Native American and Latinx, among Latinx youth, is very high and disproportionate. And while the barriers in accessing care include negative attitudes associated with mental illness, distrust of the mental health care system, lack of knowledge about treating mental illnesses, and the lack of diverse providers, including speaking diverse languages and providers who are culturally responsive. I think we can really address these barriers through this bill. And I'd like to just walk you through each of the sections. Section 1 is actually a bill that we've had for a little while, and this just makes sure that all of our private health insurance will pay for the clinical care provided by a clinical trainee. Medical Assistance in Minnesota Care already does this, and so do some, but not all, private insurers. Section 2 adds licensed alcohol and drug counselors to the list of professionals who can participate in the loan forgiveness program. So this just kind of expands our mental health workforce to include them. And that's true under Section 3 and 4 too. Section 5 would require the Board of Marriage and Family Therapy to have a more diverse board. So they'd have to have at least 2 members from outside the 11-county metro area and 3 members from a community of color or an underrepresented community. And again, we just want the boards to reflect the population of the state. Section 6 gets into the cultural training. So at least 6 of their 40 hours of continuing education have to be focused on culture. Understanding culture, its functions and strengths, the differences among and between cultures, the nature of social diversity and oppression, and the understanding of cultural humility. Now, I know you're going to ask, what is cultural humility? So according to the National Institute of Health, they define cultural humility as a lifelong process of self-reflection and self-critique, whereby the individual not only learns about another's culture, but one starts with an examination of his or her own beliefs and cultural identities. So it is a term of art that's being used, frankly, across the country. Section 7 requires the Board of Behavioral Health and Therapy to have at least 5 members from outside the metro area and 5 members from the community of color. Section 8, again, goes to the licensed professional clinical counselors related to the cultural competency work. Section 9 is for the social workers to also have at least 6 of their 40 hours be that way. And I do know that there were some questions about, why do we need to do this? I will say that 7 other states require cultural competency for their social workers with hours ranging from 1 to 6 hours. 7 other states require this for psychologists ranging from 2 to 6 hours. And so I just wanted to mention that other states are looking at doing this as well. Section 10 expands who can be a mental health practitioner. What we wanted to do was to include a student who's an undergraduate or a graduate in social work, psychology, or counseling program. You have to complete a practicum or an internship, and it's very difficult to do that work for free when you're also trying to go through school. And if they're a mental health practitioner, then the organization that is providing the supervision can actually include their work in terms of billing for services. And so that will address a huge barrier that we've seen. Section 11 expands the use of some of the mental health grants controlled by the Minnesota Department of Human Services to include paying for supervision for clinical trainees from BIPOC communities and also paying for traditional healing practices in the Native American community. You did a small part of that under the opioid bill, but we also want to include this to mental health treatment as well. The issue that this addresses is that, again, we know that more people graduate from graduate school programs than are licensed, and a lot of this is because they can't pay for the supervision. Section 12 creates a culturally informed and responsive mental health task force, and their focus is really to help us continue to look at this issue and make sure that our workforce is actually meeting the mental health needs of Minnesotans. Section 13 creates a work group to discuss possible alternative pathways to licensure without sacrificing quality. People are not passing some of the national exams, often people whose first language is not English or clinicians from BIPOC communities. Many are missing it by just a few points, but it does not mean that they won't be good clinicians. There's also been questions as to the test being culturally informed. And so what we want is for the boards to come together, discuss the barriers to licensure, any data that we can find, and develop recommendations. I want to point out that's developing recommendations. Section 14 requires DHS and the health department to convene the licensing boards to discuss and develop recommendations on how to provide supervision across all licenses and make it easier for people, especially in greater Minnesota and BIPOC communities, to obtain supervision in order to become licensed. We've done a lot with telehealth this year and telesupervision. And so I think it's time to have a greater conversation there. Section 15 appropriates funds for the culturally responsive task force. Section 16 appropriates funds to pay for the continuing education so that mental health professionals, BIPOC mental health professionals can actually become supervisors. So we increase the number of BIPOC mental health supervisors. And then Section 17 appropriates funds for the LEDCs to access the Health Professional Loan Forgiveness Program and appropriates some additional funds to target mental health professionals from BIPOC communities. I will note that LEDCs already have pretty extensive requirements for diversity training and that the Board of Social Work already requires representation from diverse communities and Greater Minnesota. Thank you so much for the opportunity to present this really incredible bill. And I just want to thank all of the organizations that worked with us to make this happen.
Thank you, Ms. Abderholden, for your testimony. We appreciate it. I know we've got hands going up here, but I'd like to get through the rest of our testifiers, and then I'll go to the representatives for questions. Our next testifier then is Ms. Yang. If you'd like to introduce yourself, who you're with, and start your testimony, please.
Yes, hi, good morning, everyone. Chair Fisher and members of the Behavioral Health Policy Division. My name is Pahua Yang, and I work at the Amherst H. Wilder Foundation in St. Paul. I want to thank you for having me here today. As both a social worker and a psychologist, I have lived through training and licensure for two of the fields represented in this bill. I have been a supervisor, a colleague, a mentor, a mentee, and many other roles for which I've witnessed incredible work be happening, as well as substantial barriers for people in the mental health field. So the bill you have in front of you is a comprehensive bill aimed at investing in building our workforce in the mental health and substance use disorders field. Both the workforce, well, really the workforce we needed yesterday, the workforce we need today, and for sure the workforce we'll need for tomorrow, especially if we want to build a better mental health system that works for everyone. The future of the mental health system rests on decisions that we need to make today or now in this time. There are many elements to this bill that I could speak about, but I want to specifically talk about the need to find alternative pathways for licensure for mental health professionals. For over 20 years across 2 states, and certainly in my 12 years at Wilder, I have watched colleagues, both at Wilder and in the community, repeatedly fail national board exams. My initial bias was they just weren't studying hard enough. But then I began to understand that I was seeing a different iteration of the same issues I've seen my entire life. That is actually, we have a whole field in psychology devoted to understanding how different populations score on different tests, especially standardized tests. So I'd just like to note that. And, you know, honestly, it reflects some of the work that I was doing when I was working in higher education with first generation college students and students of color, where I would see the same patterns. Students who were coming in with 4.0s, ranked number 1, 2, 3 out of 400, 500 students whose ACT scores were 16, 17, 18. And for those of you who haven't seen an ACT score for a while, those are pretty low scores. Ooh. I have staff at Wilder that have graduated from accredited programs, many of them nationally ranked. I have 2 women who have doctorates from APA accredited schools who can run circles around me as clinicians. And I say that without false modesty. That is just the truth. They are pioneers and leaders in our field. One of them is leading a team doing work with some of our most vulnerable children and families in a way that no one else in the country is doing. And we are getting results. The other one has an area of expertise that makes her the only one in the nation that has that expertise. And yet it took one of them over a decade and 5 times to pass the EPPP, which is the national exam for psychologists. The other person hasn't passed yet after 3 tries and has chosen a different path at my encouragement so that I could finally pay her the salary for the work she was already doing. And yet I count myself lucky among the lucky few who can say to my staff, you will have a job at Wilder whether you pass the test or not. Some of my colleagues can't do that. I have seen highly clinically skilled colleagues who have lost their jobs because of lack of licensure, and some have left the field completely, which breaks my heart. Think about the significance of this. In a time when we don't have enough workforce, we have highly competent people leaving the field simply because we, and I count myself in that, we have not been able to offer a different way to evaluate their competence for licensure. But there are also additional costs, even if people stay in the field. In our field, without a license, there is no career advancement. You make less than other people. You don't have the same title when you're doing the same work, and you can't practice independently. And too many times, highly skilled, culturally competent clinicians are getting supervised by people with less experience, but people who pass the test. I'm here today to ask you as leaders in our state for help. We have a moment where we can keep choosing the status quo. We can keep choosing to do what we're doing, knowing that we are not building the workforce we need for Minnesota, or we can choose to do something different. We can choose to build a system that works for all Minnesotans by investing in our workforce. We can choose to do the right thing during a time when doing the right thing can feel really hard. And for me, this bill represents the opportunity to do that. So thank you for hearing me today.
You're welcome. Thank you, Ms. Yang, for your testimony and for sharing what people are experiencing out there, for the work that you're doing. Next person we have to testify today is Dr. Garrett. Dr. Garrett, if you'd like to introduce yourself, who you're with, and start your testimony. Please.
Sure. First of all, thank you, Mr. Chair Fisher and members of the Behavioral Health Policy Division. I am a licensed psychologist who has practiced in Minnesota for 40 years. I'm also the president of the Minnesota Association of Black Psychologists. Most of the Black therapists achieved their degrees during the time of affirmative action during the late 1970s and 80s, when universities intentionally recruited Black students. Since then, the number of Black students in clinical programs have consistently declined. Approximately half of the Black students have now, Black therapists have now retired or returned home to care for aging parents. The result is a crisis in Black mental health care. Other communities of color and rural communities also have extreme shortages of mental health professionals. There are Africans, Hmong, Latinos, and Native Americans living in every county in Minnesota. However, there are 9 counties that have no mental health professionals and many areas that just have one provider. In addition, there is a shortage of Caucasian providers who are culturally competent in BIPOC and rural mental health care. Therapists without training in BIPOC, LGBTQ, and rural mental health are likely to misdiagnose clients, which often results in either inappropriate treatment, harm, or delayed care. The consequence is clients having failed care repeatedly and then needing expensive treatments such as inpatient hospitalization. With the opioid crisis, methamphetamine and alcohol addictions, long-term stress from the COVID-19 pandemic, and social justice issues from the George Floyd event, there's a perfect storm for mental health disaster in Minnesota right now. As you know, mental health providers are essential to a healthy society. They help maintain a productive workforce, improve academic achievement, supports healthy families and communities, offers disaster recovery supports, and reduces medical, incarceration, and social service costs as well. A significant barrier to becoming a mental health professional is the cost of education. Also, low reimbursement from insurance companies and Medicare. and low salaries that cannot compensate for high student loans. Many small communities in greater Minnesota cannot afford the salary of a mental health professional without loan forgiveness. BIPOC therapists also serve populations that require high unpaid services, such as citizenship medical waivers and advocacy dealing with systems issues, thus reducing their compensation for care. This bill provides a comprehensive array of strategies that address building a more informed and competent mental health workforce in our state. I strongly support the efforts outlined in this bill and urge your support to invest in strengthening our mental health system for all Minnesotans by investing in our workforce. Thank you for allowing me to speak today.
You're welcome. Thank you, Dr. Garrett. Thank you for being here today and sharing what you've seen and sharing the history of some of where we've been and where we've gotten to now.
Sure.
Thank you for that. We will now go to questions and comments. The first person I have is Representative Jamie Becker-Finn.
Thank you, Mr. Chair. And I just really wanted to highlight how important this is. And I wanted to actually go back to something that Ms. Abderholden had on one of her slides about comparing this work to other sort of health related fields, and just wanted to really lift up the reality is that this kind of work is, practitioners are exposing themselves to trauma, secondary and vicarious trauma from the work that they do. They, depending upon, what kind of facility they're working in, they're also, potentially putting themselves at different kinds of physical risk. And it's really hard work. And I want to thank all the testifiers for the work that they do and really emphasize how important that piece of it, because even if we paid people the same as in these other fields, are you going to choose the job where you have to be on call and take difficult calls at all hours of the day, where you're going to be exposed to sort of the worst days of people's lives on a regular basis, compared to, not to diminish the importance of keeping people's teeth clean, but, it's not an apples and oranges comparison. And it's, we have to be able to support and pay these folks for the work that they do, because all the other things we've talked about in this committee, the staffing piece is really key. We can't do all the other good things that we're trying to do if we don't have the practitioners who are trained and licensed to do the work. And so I'm really glad that this is moving forward, and I hope that others are paying attention, because we can't, there's going to be things that are in other committees that folks want to do. And if we don't have the practitioners to do the work, who are licensed to do it, we're not going to be able to do all that good that we want to do, that we've talked about in almost every other hearing. So thank you, Representative Vang. And I, again, just wanted to lift up the reality of what it's like for practitioners in this field. So thank you to the testifiers as well.
Thank you, Representative Becker-Finn. Representative Todd Lippert.
Thank you, Mr. Chair. And like Representative Becker-Finn, I want to thank Representative Vang and the stakeholders for their work on this bill. It's incredibly important. Rural communities have, and I especially appreciate the focus on BIPOC communities and cultural humility. I love that phrase. I think it's very, very helpful. Rural communities have been diverse in Minnesota and are becoming increasingly diverse. And I have a question related to this increasing diversity. So in my district, the community of Montgomery has a significant Latinx population. In Northfield, we have a significant Latinx population, a growing East African population. Just south of my district in Northfield, in Faribault, there's a very large Latinx and a Somali population. And I know the need for mental health in those communities is great, and substance abuse treatment is great. And Ms. Abderholden, in your slides at the very beginning, you had a statewide kind of a slide showing the need for mental health professionals. And Dr. Garrett talked about this a little bit, but I'm wondering if you're able to quantify the need for culturally specific mental health and substance abuse treatments in these new American communities across the state, or in BIPOC communities across the state? Are you able to kind of dig into that question at all?
Go ahead, sir.
Thank you.
Excuse me, ma'am. Apologize.
No problem. Thank you, Mr. Chairman. Representative, I'm looking for my notes because I did have that information somewhere on my desk. So in 2017, 29% of bachelors, people earning their bachelors, and 34% of people earning their masters from Minnesota's mental health post-secondary programs were people of color. Yet in 2019, only 12% of licensed mental health providers, including practitioners, professionals, and LADCs, were people of color. So a very small percentage. It's certainly not enough.
Thank you, Ms. Apfel.
Absolutely, Mr. Chair. I'm wondering if Dr. Garrett has anything to add on this question as well. He was speaking to some of that in his remarks.
Dr. Garrett?
Yes. As of last year, we had 25 licensed African-American psychologists. Now, there are other African-American therapists who are like social workers, marriage and family therapists, and have substance abuse credentials as well. But there are 25 African-American psychologists. Of that 25, 8 of them now are child adolescent therapists. And so it's a really kind of scary situation because there's thousands and thousands of children of color. And just looking at the African-American children, there clearly are not enough therapists for African-American children, but for adults as well. And of that 25, about half of them are of retirement age already. Already, we're at that point. And there's no way that we can serve the African-American community ourselves, but also when you're a Black psychologist, you also serve the other communities of color, because when a person is in the system and if they request a culturally competent therapist, the largest number of therapists of color are African-American. And so more often they get referred to an African-American. So we are treating not just the Black community, but other communities of color. In my practice, it varies somewhere between 40 and 50% of my clients are actually Hmong, actually. But I serve all the communities, including the white communities as well. But the numbers are dropping for Black psychologists, and it's at a critical level at this point in time.
Okay. Thank you, Dr. Garrett. And I also see we have somebody from the department that can also speak to us on this issue. Ms. Terry Fristma, please identify yourself and go ahead.
Thank you. Thank you, Chair Fisher. My name is Terry Fritzma, and I just wanted to jump in to just sort of take a step back. I'm the lead healthcare workforce researcher at the Minnesota Department of Health, and so we do track demographics for mental health providers. And in the latest survey that we have, just across the board, mental health providers are anywhere between 88 and 90% white. And in the state of Minnesota, according to the demographer's office, Minnesotans are about 20% people of color. So it just gives you a broad breakdown on kind of the mismatch between the demographics of providers and the state as a whole.
Thank you, Ms. Fritzma. Appreciate the statistical information there. Representative Lippert, any further follow-up questions?
No, Mr. Chair, just a comment. As Dr. Garrett was speaking, I was thinking about both my experience as a pastor and time in my own time, in therapy as well. And the question is, will this person understand me and understand my situation? And so I think the need for cultural humility and eliminating these obstacles is incredibly important. So I thank you for this work.
Thank you. Next, we'll go to Representative Frankie.
Thank you, Mr. Chair. Thank you, Representative, for bringing this bill forward. It's definitely needed. We need to fill these gaps and create these opportunities to help this. I want to make a quick comment and then just have a little bit of advice for Representative Vang, hopefully on this bill. But, I want to go back to what Ms. Yang was saying about the testing. I'm one that believes that, the quality of your experience doesn't always come from testing, especially when it wraps around this field. If experience didn't work, then any 12-step program or any way that a lot of these recovery programs are built would not work, because it causes you to go out and find somebody who's doing it and who's doing it right, and you try to work with them. And so sometimes the testing doesn't always get it right, and there's definitely a need and a passion that somebody has to have to be in this profession. So I applaud everybody that works within this industry, and I thank all of the testifiers and anybody who does this work. To the bill, I was noticing in section 17, the appropriation for the loan forgiveness program, and this is just a comment for the representative, hopefully that can be taken forward. It says here that a third of the money is going specifically to Black, Indigenous, or people of color. And I just want to ask you to think about including the other groups of underrepresented communities in that loan program forgiveness, so that we can make sure that all of these underrepresented communities, people with, the sexual orientation, gender, the LGBTQ plus community, take a look at that, because I would really appreciate that. And that's all I have, Mr. Chair. This is a good bill, and I'll be supporting it. Thank you.
Thank you, Representative Frankie, for your comments. Next, Representative Thompson.
Here, with the the importance of first of all the conversation, but also of the work. For myself, after we lost Philando, I lost my mother. I lost my mother like right after, a few weeks after, and then like a few weeks after that, my son was shot 6 times at a funeral. So I didn't see this 20-year-old kid. I just saw like the little baby I used to lay on my chest. But I would come out of that and like go back to work, and I would just work extra hard. And people at work was like, well, you need to go and talk to somebody. And I always said, man, I'm not crazy. I'm not going to see a psych. I'm not going to see a behavioral. Nothing's wrong with me. But I did. I scheduled some time to see a behavioral health specialist. And one of the first things I said, because it was somebody who could resonate with what I was going through, was, man, I was crazy not to come and see you. That was one of the first things I said. So I admit myself, like we walk around with this armor on, like we have no kind of, like we're, especially men, we walk around like we just have no. And so I was going to say this is really important to me, and I want to thank you, because this conversation, like it needed to be had. And what better place to have it than here with this body who can actually create the change we want to see. And I want to say thank you again to Representative Frank for your words and including everybody. Like because this is just not a white thing. Everybody suffers from mental health. And we think we don't have problems, when we really do. We do need to see somebody. So I say thank you again, guys, for this conversation.
Thank you, Representative Thompson, for sharing your background and sharing what you've been through and how important what we have in front of us is today. And I want to thank the entire committee and our testifiers. That these are tough issues, and it's important that we get these right. And we appreciate the focus that Representative Bang has brought forward for this bill, the people who are willing to come forward, share what they've seen, what's happening now, what's been happening historically, and where we need to go forward. And it also represents how this is everybody working together. This is not Democrat versus Republican. This is all of us coming together because that's what it's going to take to continue to solve these problems. And I appreciate the dialogue that we've been able to have today, and I encourage that we continue this. I encourage that as our authors of the bills that have been working on them today, continue to reach out to Representative Frankie, Representative Baker, the folks on the Republican side who are just as passionate on these issues to make sure that we're getting it right so that we've got a system that works for everybody as we go forward. Seeing no other comments or discussion at this point in time, I renew my motion that House File 970 as amended be recommended for referral to the Human Services Finance and Policy Committee. The clerk will take the roll.
Fisher.
Fisher, aye.
Fisher, Fisher, aye. Frederick.
Aye.
Frederick, aye. Frankie.
Aye.
Frankie, aye. Backer. Backer. Baker.
Baker, aye.
Baker, aye. Becker, Finn.
Aye.
Becker, Finn, aye. Hanson. Hanson. Katiza Wattoon.
Aye.
Katiza Wattoon, aye. Lippert.
Lippert, aye.
Lippert, aye. Moeller.
Aye.
Moeller, aye. Pearson. Pearson.
Aye.
Pearson, aye. Thompson.
Thompson, aye.
Thompson, aye. Backer. Hanson. All right, there being 10 ayes and 0 nays, the motion prevails.
Okay, with 10 ayes and 0 nays, the motion has prevailed and House File 970 as amended is recommended for referral to the Human Services Finance and Policy Committee.